like we do still have a few folks joining. In our overview talk, we discussed the idea that there's multiple levels of cost and value that need to be considered in evaluating the sustainability of our various health innovations and healthcare programs that we prepare. And today's talk is meant to focus on primarily the patient level perspective. And so we are joined by Dr. Marcelo Perraillon from our Colorado School of Public Health. He's an assistant professor in the Department of Health Systems Management and Policy, and has a secondary appointment in the economics department at the downtown Denver campus. His research focuses on the evaluation of the effects of healthcare policy on costs, quality, and outcomes using statistical designs that permit the estimation of causal effects from observational data. His areas of interest include long-term care, research, and Medicare/Medicaid policy evaluation. He teaches graduate level classes on statistical and econometric methods for health services research, economic evaluations, and health economics. And so if you're interested and want more, I suspect you could sign up to take his class. And before obtaining his doctoral degree at the University of Chicago, he was a researcher at the National Bureau of Economic Research. He co-directs the Population Health Share Resources Corps at the University of Colorado Cancer Center, as well as the doctoral program in health economics. And so please join me in welcoming, we would all clap if we were there in person, Dr. Perraillon talking about economic evaluations of healthcare intervention, defining value, affordability, perspective, and patient-reported outcomes. Thank you.
Thank you so much for the introduction. And first, I just wanted to show my face to see that I actually am a real person, but I have to switch computers because I want to use my tablet and I don't have a camera in my tablet. So give me 1 second while I do the change. Okay, so you should be able to hear me. If somebody could confirm that, that would be great.
We can hear you.
Okay, perfect. So today I'm going to focus the talk on sort of the very basics of economic evaluations and particularly defining goals and why we do economic evaluations. And that part is very important to understand why economic evaluations are done in one particular way, which can be a little bit peculiar sometimes. And I'm going to describe the key elements, which are perspective, time horizon, and relevant of cost for the decision. And the key metric that results in an economic evaluation, which is the incremental cost effectiveness ratio, ICER, and which is essentially a way of defining value. So this is the part that I think is key for the seminar. And I'm going to focus on the outcomes and why outcomes are measured the way they are measured, and particularly this measure of quality that we use in health economics, which is a little bit unusual in terms of how it's done, and whether that's a bad thing or a good thing, or different approaches that one could use to do this. I'm going to use several examples to go back and forth among different issues. So I'm planning to use more or less, it's 12:05, more or less 40 minutes or 45 minutes, so I can leave at least 15 minutes for questions. So going back to the very, very, very basics, this is the standard definition. If you're interested in cost effectiveness and economic evaluations, this is probably the best book that you can buy. It's a book published by some scholars in the UK, and the reason is that contrary to the US, cost effectiveness is used in Europe to make decisions about what health intervention, what particular technology is going to be covered or not. So the standard definition of economic evaluation is the comparative analysis of alternative courses of action in terms of both their costs and consequences. So one thing that is key is that these are alternative actions. So you can think about different ways of conceptualizing the alternatives. They are health interventions like screening programs, new way of delivering care, say a laparoscopic surgery or a technology, a laparoscopic surgery versus a robotic surgery versus a regular surgery, particularly new medications. You probably have seen many economic evaluations of new medications, new imaging technology. There is also like this that can be done about dosage or screening frequency. A lot of cost-effectiveness studies have been done trying to figure out is screening for prostate cancer every year, every 5 years, every 10 years, how often should we do it? What are the costs? What are the consequences? The other key element is always a comparison. And this is very, very important to understand the logic of economic evaluations. It's always a comparison in the sense we're comparing the new thing versus the old thing. And how you compare things, of course, that it makes a huge difference. So if you compare the new medication versus placebo, that's completely different than comparing the new medication to the current medication, which is also proven to be effective. So obviously how to compare things is very important. And it can be the old drug versus the new drug, the new imaging technology versus the old imaging technology. A valid alternative in cost-effectiveness analysis sometimes is do nothing. So is the new alternative versus doing nothing. Or the other most common alternative is the new thing versus the way we think we do things now. And this is something that causes a lot of confusion sometimes when you read papers or when you try to apply a cost-effectiveness result to your own settings, because sometimes how you define usual care, it's very different in different settings. So how University of Colorado hospitals define usual care in one particular area may be very different from the Mayo Clinic or MGH in Massachusetts. So it's important to compare to take into account what is the comparison. And then, so we have alternatives that can be one versus the other, or can be several alternatives compared to a baseline or something like that. And we compare those things in terms of cost and in terms of consequences. Cost is usually easy in the sense that it's always measured in dollars or whatever unit the country uses to measure monetary units. The consequences is the part that we are going to focus on today. And those are essentially outcomes. So we are comparing different interventions in terms of their cost and in terms of their outcome. And there are many different ways of measuring outcomes. Usually in cost effectiveness, we talk about natural units like cases detected, cases averted, years of life gain, disability days. Those are natural units. Life years gain is also considered a natural unit in this framework. And however, we care about increasing life years between alternatives, but also we care about the quality of years. So usually the most common measure of outcome in cost effectiveness is what we call the QALYs. So the quality adjusted life years. So it's a measure that adjusted the life years gained by quality to create this quality. And we're going to focus on why we do it that way and how we do it. But this is the very foundation of economic evaluations. We are comparing different alternatives. We are comparing in terms of cost and consequences. And these different combinations of the elements that I described below, essentially the cost and the consequences, create these different types of economics evaluations that, in a sense, they are just a taxonomy that sometimes cause a lot of confusion because people tend to say the pet peeve for anybody who does economic evaluations or teaches economics evaluations is confusing cost-benefit analysis with cost-effectiveness analysis and then with cost-utility analysis. So just to define terms, there's a type of a study that is called cost savings or cost averted. It's a study that just considers the cost between the alternatives. Is doing A cheaper than doing B? Does A save resources compared to the other alternative? These are very popular and studies that people in public health and everybody wants to show that the new thing that they just created has the potential to save money. Because effectiveness in economic evaluations, we consider these partial type of studies that I'm going to explain in a second why they are partial type of studies. Then I will say that the most common kind of confusion is between cost-effectiveness analysis and cost-utility analysis. So cost-effectiveness analysis consider cost and outcomes, but outcomes are measured in natural units. So cases detected, years of life gain, that will be like what the definition of cost-effectiveness analysis. Then to make things more confusing, there is cost-utility analysis, which is exactly the same as cost-effectiveness analysis, but then this considers the quality of the life years, and the outcome is usually measured in QALYs. So this is still a sort of a very sort of confusing taxonomy, in the sense that most people will say that cost utility and cost effectiveness analysis are exactly the same thing. And in the US, I will say that that's the language. If you sometimes read different textbooks, different journals, or different authors, you may get confused between cost utility and cost effectiveness analysis. The difference is that one takes into account quality of life years, the other measures in natural units. At the end, most people will say that cost effectiveness analysis refers to both cost effectiveness analysis and cost utility analysis, but it still causes a lot of confusion. And then there is something that is called cost benefit analysis, which is different from what we are going to consider today. And the idea is that you compare both the consequences and the outcomes in terms of monetary units. And this has an important effect, which is that you need to be able to translate outcomes into money. So say, if the outcome is cases detected, so what is the monetary value of a case detected or a case averted? And obviously, it has a lot of practical problems, ethical considerations. You will need to consider the value of life itself. And if you have if you read some of the controversies about lockdowns versus the monetary value of saving lives, this is completely related to cost-benefit analysis and these methods that we have to evaluate the monetary value of a life. But we don't do cost-benefit analysis for health interventions. It's very rare the study that do cost-benefit analysis. So as I said, it's a little bit of a persnickety thing to make the difference, but we don't do cost-benefit analysis because we don't translate outcomes into money, even though I'm going to show you today that, in fact, we kind of do when we use a threshold to make decisions. But today we are going to focus on these two things, and in particular, cost-effectiveness analysis that compares the cost and the consequences, and the difference is how you measure the consequences, whether you measure as natural units, whether you measure quality-adjusted life years. But again, we don't do cost-benefit analysis, even though in a lot of papers you are going to read that we did a cost-benefit analysis. Technically, it's really not a cost-benefit analysis, most likely. So here's the part that is very important for today's talk, is why do we do economic evaluation? So from the point of view of economics, the goal of an economic evaluation is to inform decision makers about the efficient allocation of scarce resources. We don't have an infinite budget for anything that we want to do. So given that there is constraints on the budget, how can we allocate resources so we maximize the benefit of those resources? And we are going to see that cost effectiveness analysis is essentially a way of maximizing the unit of outcome. So in this case, it's going to be, we are trying to maximize the quality adjusted life years, given that we have a fixed budget. To do so, we compare costs and consequences. And the part that is important to understand, say, cost effectiveness analysis versus other types of studies that are more related to affordability and sustainability is, the goal of the different goals produce different studies. So cost effectiveness analysis is this, the goal is trying to allocate scarce resources in an efficient way. If you want to analyze the impact of using the new technology is going to have in a hospital or a health system, then probably you will want to do a budget impact analysis. And if you want to analyze whether a particular intervention is going to be sustainable from a particular point of view, then you may want to do a different type of financial analysis. So figuring out what is the goal of the analysis, then it's important to understand what study you should be performing. And this is a blank thing that is not a blank thing. Sometimes this software has a problem. So the key elements, if the goal is to inform decision makers about the most efficient allocation of resources, the analytical perspective is key. So every time you read an economic evaluation study, the first thing that you should try to understand is like, what analytical perspective they use. This is not a perspective, is not an opinion or stakeholders. This is an analytical perspective, which essentially means from which point of view are you measuring cost and consequences? So typical perspective of a study are a payer perspective. So from the perspective of Medicare, Medicaid, insurance company, the government, the VA. So this will be analytical perspective that you can use to perform an economic evaluation. It could be society. So society is the most comprehensive analytical perspective that consider all costs regardless of who is going to pay for that particular cost. This has very important consequences because a cost for a particular perspective may not be a cost for a different perspective. A cost for Medicaid may not be a cost for the patient. A cost for the patient may not be of any interest for Medicaid and Medicaid. So the analytical perspective is key. The panel on cost effectiveness research recommends doing two perspectives. Whatever perspective is essentially paying for the study, or whatever perspective is the relevant perspective. If you are doing a study from the perspective of the VA, then do it for the perspective of the VA. If you're interested in Medicare, Medicaid, do it from that perspective. But the recommendation is please always do also a study for the societal perspective, which means that you should include all costs, including the cost for the patient. And the idea is this is the most comprehensive way of doing a study, and it allows for comparability of the studies that is very important in cost effectiveness analysis. This has created a lot of confusion. A lot of studies say, we did it from the perspective of society. When you go to the details, turns out that they really didn't do it for the perspective of society. They use a more limited perspective. Note that most economic evaluations, or all economic evaluations, are not done from the perspective of the patient. Essentially, we don't necessarily consider the perspective of the patient when we consider the cost, because may not be relevant for the particular perspective that we are taking. Costs of the patients are considered to be included in the societal perspective, which is again is the most sort of broad perspective that you can take. Is also the most difficult perspective to do in any study. So sometimes people take shortcuts, and you just cannot measure every single cost that is going to be relevant. I'm going to say that more about that in a second. However, the consequences are always measured from the perspective of the patient. So we measure the cost for different perspectives, but the consequences, the outcomes, are always for the perspective of the patient. So the perspective of the patient is central to economic evaluations. It's just that it may not be central to the cost piece. And the reason is that the patient may not be the decision maker in terms of deciding which interventions are going to be done or not. And the time horizon and the relevance of cost for the decision are the other key ingredients. One study done with a time horizon of 5 years is going to be completely different than the study that is done of 5-year horizons or a lifetime horizon. So the time horizon is very important. Essentially, the time horizon is for how long are we going to measure the cost and the consequences of these interventions. And the third is the relevance of cost for the decision. So I just said it's important, say for the perspective of society, you want to include every single cost that is going to be resulting from these new technologies versus the old technology. But as we are about to see, the costs that really matter are the costs that are different between the two technologies. If you can argue that a cost is going to be the same regardless of which technology you are going to employ, so then you don't have to consider that cost in the study, and that simplifies issues a lot. So this is the key outcome of in a cost effectiveness study, is the famous or infamous incremental cost effectiveness ratio, which is essentially the cost of one of the alternatives minus the cost of the other alternative divided by the difference in the effectiveness of the alternatives. The incremental part is very important. We are not comparing average effectiveness, say the average cost compared to the unit of effectiveness and the average cost compared with the unit of effectiveness here. We compare incremental cost with incremental effectiveness because this matches the decision that we want to make. Essentially, the decision is, should we do A versus B? And what we want to understand is like, well, how much more expensive is A versus B compared to the improvement in the outcomes that we get for doing A instead of B. And this is central in economic theory. This is basically the foundation of economic theory, is maximization subject to a budget constraint. And this logic that the optimal solution arrives when marginal benefits equal marginal cost is completely central, and it's very important to understand. So it's always sort of, we compare incremental cost divided incremental effects, and we always do this incremental thing because it matches the decisions that we want to make. And note that the ICER is going to be dollars per unit of outcome. So the most common is going to be dollars per unit of quality. So dollars per quality adjusted life years that are gained from one intervention versus the other. So let me show some examples that I'm going to be using for the next 20 minutes. So one example of a cost saving study that again will be a partial study. So did a smoking cessation program for Medicaid beneficiaries save money? For example, you can do this study 5 years, it's Medicaid perspective. Only the costs that are relevant are the costs for Medicaid. We are not consider outcomes. Again, these are very popular. Everybody wants to do a cost-saving study, but saving money is not the objective of healthcare necessarily. We do care about outcomes. A lot of new things are more expensive, but they are also going to provide a benefit that we want to take into account. I will say that the most common type of cost-effectiveness studies that you see are medications. So, for example, is the new medication that cures hepatitis C cost-effective? Comparing that means comparing the cost and the consequences using QALYs. An alternative research question for this would be, is the new medication worth the extra cost? Is the new medication that is going to be expensive worth it in terms of the benefits that it's going to obtain? You can do the same for a new surgical procedure for back pain. Is it worth it? To the extra cost of doing this surgery, it's worth it compared to the benefits that we obtain from the surgery. And also, you have probably seen a lot of cost-effectiveness studies of the screening programs. How often do we screen? This will be slightly different from the other examples in which you don't consider alternative A versus alternative B, but actually the frequency of one alternative versus a baseline or different quantities of that alternative. So if we're going to use ICER to make decisions about what's going to be used or not, what not going to be used, what do we do with the results of the ICER? There are some particular scenarios that are fairly easy to figure out what we should do. So these are the two easy decisions. If B, let's suppose that B is the new alternative compared to A. If B is more expensive and less effective, then we don't even do an economic evaluation study, right? More expensive and less effective, we're usually not interested in this. So this is an easy decision. We wouldn't want to do B. If B is less expensive and more effective, we would prefer B as well. So there is not a lot of choice here either. Then the not so easy decisions are B is both less expensive and less effective. So it's cheaper, but it's less effective. Usually in the US or in other advanced countries, it still is not very appealing to do that because we care about the effectiveness of a particular intervention. In developing countries, this could be an interesting option because maybe the less expensive medication, even though it's less effective, is not terribly less effective that we can actually tolerate that particular technology if that allows for affordability. And I will say that this is sort of the situation that cost-effectiveness studies are done. The new alternative is both more expensive but more effective. So it's the new medication that it is more effective, but it's also super expensive. And this is typical in cancer type of technology, and drugs and procedures are ridiculously expensive. Some of them are ridiculously good, some of them are terrible, and that's where the notion of value is going to come. So usually we don't, the technical term is that some situations are dominated by the other. In reality, cost-effectiveness analysis focuses on the situation in which you have a more expensive technology, but you also have a more effective technology. So you want to compare the two. So here's the part with value in cost-effectiveness. This is how we define value. If B is more expensive and also more effective, how do we know that that has good value or whether that's worth it? So for example, if we find that the new medication is $400,000 per quality or $20,000 per case detected, what do we do with these numbers? By itself, we cannot do much. I mean, value is a relative concept. We will need to compare those ICERs to different alternatives. So we need to compare the ICER that is measured in terms of quality to ICERs that are similar, also measured in terms of quality adjusted life years. Or if we find that it's $20,000 per case detected, we will need to compare that to alternatives that also use case detected as the measure of outcomes. The reason why so let me go back. If the most important thing is that value, it's a relative measure, so then we need a relative type of metric to figure out what is valuable or not. The reason why qualis are used a lot is because we have thresholds or rule of thumb to decide what's valuable or not. In the US, anything below 200,000 per quality adjusted life years or $150,000 per quality adjusted life year will be considered cost effectiveness and will be considered to have good value, and put quotation marks in good value. I don't have time to go over the threshold, but it has a long history and controversy in economic evaluations. It's both, the threshold is both the willingness to pay for an extra years of life and the opportunity cost of that extra years of life. Notice that this is the part that is very important. If we are going to use a threshold, the threshold if the threshold is going to be measured in terms of quality adjusted life years, the threshold is really the value of one life adjusted for quality. Because what we are saying is, as a society, or because we have this rule of thumb, we are something that is more than say $200,000 per quality is not worth it. So we are saying the max that we are willing to pay for an extra year of life adjusted for quality is going to be $200,000. Anything more than that is not worth it. Obviously, you know, but by law, we don't use cost effectiveness analysis in this country to make coverage decisions, but this is the way that could be done in different countries. Although not even different countries use only cost effectiveness analysis. Usually, cost effectiveness studies are just one measure that they use, but other things are taken into account. Even in the UK, for example, there's a panel that if something that is below the cost effectiveness threshold is very likely to be approved. Something that is above the threshold may not be approved, but it depends on what other considerations you may use to make the decision. And they use considerations as, say, for example, is that an intervention that saves the life of children? So that's more, they consider that. If you think about value in these terms, then it is a very narrow definition of value. We're not taking into account equity concerns. We are not taking into account future advances. For example, one rationale to approve a new technology is like, well, it's terribly expensive. It doesn't improve a year's life in this particular situation, but it's a very promising technology. So if we let physicians and we let the field use this technology, we may find uses for this technology that are very good. So we don't take that into account. Other organizations in the UK that they use cost effectiveness to do this, they actually do consider this type of issue. So again, not even in countries where you think that cost effectiveness is used to make decisions, they entirely use cost effectiveness. So the definition of value in cost effectiveness, as a summary, is just the incremental cost divided by the incremental effectiveness. Is the extra cost worth it in terms of the extra outcomes that we can obtain? And you know, comparability, and I'm saying comparability 3 times, it's really super important, again, because value is relative. And if we are going to compare different technologies, if we are going to compare the medication for hepatitis C versus the back surgery technology, we need to measure them in the same unit of outcomes. And hopefully, we need to create studies that are done from the perspective of society, because then we are going to include all the costs and we can make comparisons. If we don't do that, then we cannot make comparisons, and then value is a relative concept, so that we don't know what to do with a study that will measure in different units. So that's the reason why qualis, this quality adjusted life years gained combined with quality, is one of the most used outcomes, and is the outcome that the panel on cost effectiveness studies recommend. There are a lot of problems with using that outcome only in any study, but the reason is comparability. If we're going to do cost effectiveness analysis to decide, or just define a value in terms of a comparison of incremental cost with incremental outcomes, then we are sort of narrow to compare outcomes that are measured in the same way. And this is the reason why quality adjusted life years, even though may not align with patient-reported outcomes in general or patient preferences in general, is still the most used outcome, and the outcome that the panel on cost effectiveness studies recommends to use. So going back to sort of the efficient allocation of resources, I just told you that the goal of economics evaluation is to efficiently allocate resources. And here's a sketch of the theoretical approach that, or how do we connect the cost effectiveness analysis and the ICERs with efficient allocation of resources. So here's how you will maximize quality adjusted life years. Suppose that you have a finite budget for a particular year. So you could maximize life years gain in the population adjusted for quality by first sorting the interventions by lowest ICER to highest ICER. And then what you do is that you do the first intervention first, the lowest ICER first. Then if you have money remaining, you do the second. If you still have money, you do the third until you don't have money anymore. If you do it that way, you just maximize, you can think of this in an abstract social planner or society, they just maximize life years gain in the population given the budget constraints. So this is sort of the rationale of doing cost effectiveness analysis or many different interventions to make decisions about what should be covered and what shouldn't be covered. And again, I don't think that there is a single economist or that will tell you that this is the only thing that we should take into account with making decisions about what's going to be covered or not. And also people will tell you that society shouldn't be doing this exercise to decide how things are going to be covered or not. But it's definitely one of the aspects that you can take into account to decide what has good value or not. But again, it's a very narrow definition of value in this sense. So here's one example that I like to use a lot. And the case of Sovaldi also highlights this difference between value, affordability, and sustainability, and the different type of research that you need to perform to give you answers for all of them, or to tell you what is good value, what is affordable, what is sustainable. So Sovaldi entered the market in 2013. It's a very effective medication, essentially a cure for hepatitis C. When it launched, the 12-week course of treatment will cost $84,000 per patient, which is a lot, but then again, it's almost like a cure for hepatitis C, so it's a very, very good technology. The cost effectiveness analysis question will be, is the extra cost of Sovaldi compared to the standard treatment worth the extra effective? Is it worth it as a medication, even though it's $84,000? So some studies found that Sovaldi is actually cost effective, not for the general population with hepatitis C, but it's very cost effective with people that are in a more advanced stage of the disease, because for these people, the cost of treatment is also very expensive. So say for a second that we show that Sovaldi, say, if not at 84,000, let's say that we show that at 64,000, Sovaldi is actually a good value. In this kind of narrow sense that we say it's good value when we compare those 64,000 or the extra cost that maybe less than 64,000 to the extra years of life that people gain, because essentially they don't have hepatitis C anymore and they don't have any more complications for the rest of their life. So if we do that exercise, we just said that that has good value compared to the other alternatives that we have currently. So we should be doing it. Now, that study doesn't tell you whether it is affordable for a particular perspective. So what happened with Sovaldi is, like, again, it's a miracle. It's a fantastic medication. It's $84,000. That was the cost in 2013. Well, it turns out Medicaid cannot afford to pay for Sovaldi in many different states. And that tells you, like, even if you could say that Sovaldi has good value in this comparison of incremental cost with incremental outcomes, you still have the problem of affordability. So many states were sued because they couldn't afford to cover Medicaid, and the price has come down. And it's also a fascinating story about how medication prices are different in different countries. Egypt actually costs $5 the treatment of Sovaldi. So technically everybody in Egypt can get access to Sovaldi and not have hepatitis C. Here we have problems even covering Sovaldi in prisons and jails. But that will be the difference between value based on cost effectiveness and affordability, which is very different from sustainability as well. So the study that usually is conducted to figure out the impact that a new technology is going to have on the budget is the budget impact analysis. So budget impact analysis is a type of financial analysis with the goal of ascertaining the impact of intervention of finances. So it's different from a cost effectiveness study. Usually what is key is that the perspective tends to be different. The perspective is the payer. Even though the value could have been done using a societal perspective, for budget impact analysis, you always care about the perspective of the payer. Say in the UK or Europe is going to be the government that is going to pay for this. In the US, we can think about doing a budget impact analysis for the perspective of Medicare or Medicaid. It's usually short term, 3 to 5 years, compared to a cost effectiveness study that it could be lifelong, because you want to figure out whether the new intervention is going to have an effect over life years accumulated. The key ingredient is that how many people are going to use the intervention. So that drives a lot of the result in a budget impact analysis. So again, so there's the difference between cost effectiveness analysis, a budget impact analysis, and then you could do a sustainability type of a study to figure out, can we as a hospital sustain to use this technology? But these are different type of studies. One is an economic type of a study, the other is a financial type of a study. Going back to the patient perspective, so again, the only analytical perspective that take into account the patient is the societal perspective. And in those particular costs, you care about, say, transportation costs, family time not working, and this can be significant and this can be very important. For example, if you are going to compare a new type of performing surgery that is laparoscopic, and the patient is going to be able to go back to work in 2 days, with another alternative that involves open surgery that maybe the patient is going to be able to go back to work in 10 days. So those 5 or 6 extra days of work, they have value, and you should measure those costs. Consequences and outcomes, as I said, are always measured from the perspective of the patient. And one of the most important is extra years of life gain, because we all care about living longer, and it's something that most people will say that it is very important. Modern medicine is so good at keeping people alive, but maybe the quality may not be fantastic. So to do qualis, what we do is say we have 10 extra years of life gain, and we are going to multiply by a number that is between 0 and 1. And that number is going to reflect the quality of those extra years of life. If the quality is not that great, the number is between 0 and 1 is going to be lower, say it's 0.3. So instead of 10 years of life gained by the intervention, we say that it's 3 years quality adjusted life years, which has multiplied the 10 times the 0.3. If the quality of life is very good, then say it's going to be 0.95. So then it's going to be 9.5 quality adjusted life years. So that's a very basic sort of use of quality adjusted life years, which means that we need to find a way of finding that number between 0 and 1 that is going to reflect the quality. And this is the part that is very peculiar how this is done in economic evaluations. Quality is conceptualized as preferences, and preferences over health state. So that measure of quality that we use, it's a measure of how patients prefer one health state versus the other. I don't have the time to get into any sort of detail about where this comes from, but it comes from utility and this idea that economists have that people have utility, or is a measure of happiness, or it doesn't need to be even measured, but that's how people make decisions. And then there's a type of utility that is a utility under uncertainty that you can actually measure. So those are preferences over health states that are hypothetical and uncertain. So that's the origin of why we measure quality in the way that we measure. In practice, you need 2 ingredients to measure quality of life in economic evaluations. One is you need to be able to define health states. And this is a little bit complicated because you can define health state in many different ways. The most popular instrument that is very simplistic and crude is the EQ5D scale. So the EQ5D has 5 questions: 1, mobility, self-care, usual activities, pain and discomfort, anxiety and depression. And people can say, I have no problems, I have some problems, I am confined to bed. So it goes from 1 to 3. There's a new one that goes from 1 to 5. But it's essentially 5 questions with 3 alternatives that is going to define about 256 health states. So what economists do is then they measure sort of how people prefer one health state to the other in a hypothetical situation. And there are methods that are, the most popular one is something that is called the time trade-off method, to ask people to rate and give preferences over these different health states. For example, these are expensive studies and they are difficult to conduct. So in the US, there have been one study to measure the preferences of a health state. They asked a large representative sample of the US to evaluate the health state defined by the EQ5D. These studies are expensive and you need to train responders, so you can help them think about how to make these particular evaluations. Before that study in 2005 that was published, but the study was conducted in 2001, in the US, we used to use the preferences of the UK because we didn't have preferences that were representative of the US population. So for example, the state 311 will be the state that is 3 here, 1, 1, 1, 1, which is essentially a person that is confined to bed, but otherwise the person is fine. You know, whether that health state is likely or not is a different question, because a person that is confined to bed may not be very happy in terms of depression and anxiety, but hypothetically that state is valued at 0.44. So instead of, if a person is 10 years in that state, technically the person is 4.4 years when you adjust for quality. For example, moderate pain, but no other problem, it's 0.93, but severe pain with no other problem is 0.57. So this is how kind of this is implemented in practice. And as I said, it's a little peculiar. So for example, if you do a cost effectiveness study, well, say that you do a cost effectiveness study based on a clinical trial. So you measure the effectiveness of a new medication, and you have that measure of effectiveness that hopefully you compare to, say, the most current or the usual care alternative. And you ask people to complete a questionnaire like the EQ5D. Those are the health states of the people that participated in the study. But to score the EQ5D of those people, you are going to use these preferences that are the representative preferences of people in the US. So those are not the quality of the people who participated in the study. Those are the qualities. They're called like community type of quality. And this is a little bit of a controversy perhaps in the US, but it's very clear in other countries. The reason why you do it this way is because you're using these cost effectiveness studies to allocate scarce resources, and you want sort of the preferences of a society to guide you in doing that. And it's obviously you are going to get very different results if you measure how people who are currently in that disease state, they will tell you whether they prefer that disease state to not being in that disease state. It's very different if you ask hypothetically to a representative sample of the population to tell you how they value that particular state. So this is, again, a very peculiar way in which preferences are valued in cost effectiveness study. And the reason is these theoretical links to how resources should be allocated. And then the other reason that drives a lot of this research is this idea of comparability. If we are going to use cost effectiveness analysis to make comparisons, then we are sort of stuck in this world that we need to measure the outcome in a way that is common to all these different conditions that we are studying. So it's quality a good measure of outcome? Obviously, yes and no, and most likely no in many different situations. Again, obviously, life years are important. We all care about it, but you could consider other patient-centered outcomes. But then we have the problem of comparability. For example, consider again the case of back surgery or back pain. So the surgery is done to relieve back pain. Therefore, life years may not be the most relevant metric. However, quality is going to be the most relevant metric in this peculiar way that we measure quality. So if we were to do a cost effectiveness analysis of that particular back surgery, then life years is probably, say, alternative A and B, life year is going to be 10 in both. So, but what is going to drive the result? Well, the quality of care, of the quality of the pain. So as we saw in a representative sample of the US, moderate pain is 0.93, severe pain is 0.57, the difference is 0.36. So in the denominator, it will be 0.36 weighted by the time that you use, and you will compare the incremental cost of the two alternatives, and what will drive that will be the quality of life, and that will be the measure of the pain. This is a very crude instrument, and there's a lot of research and a lot of discussion of different ways of doing this, but we always go back to this idea that we are kind of stuck in this world, that for cost effectiveness analysis, it's not that any other type of patient-reported outcome or whatever is relevant for the patient is not important. It is this problem that we have, that we want to compare different alternatives, and to compare the different alternatives, we need to compare with a different outcome. Now, you could design a study that you report many different outcomes. So you could report, and sometimes it's done that way, that you could report whatever metric is relevant for that particular disease, but then you could only compare the ICER to similar studies that have used the different metrics. Or you could present a study in which you use QALYs, but usually use different metrics. Just to end, so the EQ5D is usually not used a lot in the US because sometimes when people design clinical trials, they are not thinking about performing a cost effectiveness study. So there's a little industry, a little area within cost effectiveness analysis that is about predicting preferences, essentially predicting that measure that goes from 0 to 1 from different instruments to the EQ5D. So you could say, ask about the SF12, and then use that in a model, in statistical model, to make predictions about that number that is between 0 and 1. So that's a big kind of area of research doing cost effectiveness analysis, going from different metrics of different patient-reported outcomes to these preferences over health state. And one of the problems, and this is another issue that is very easy to see why is a problem. If these studies in which you ask hypothetical representative sample of the population to value these different health states, it will be a problem if you have an instrument that defines 1 million health states or 4 million health states. And that's actually the problem of something as simple as the SF12. Because when you consider that the SF12 has multiple alternatives for each of the questions, that combination will give you several thousands of health states. So that's why we go back to, well, then we're stuck with a very kind of crude instrument that may not be able to capture a particular situation. But that's the how we are in cost effectiveness analysis. And again, it's very important to understand the purpose of economic evaluations. Is the efficient allocation of scarce resources. And from that, we derive this notion of value that, again, is very narrow. And I think that everybody understands that is very narrow. A lot of medical societies are coming up with guidelines on what procedures or what medications are valued, and they usually use cost effectiveness analysis as one of the measures, and then they consider other characteristics, which is not sort of that much different from, say, UK or the Netherlands, when they actually use cost effectiveness analysis to make decisions, because they don't just use the ICER, they also use other criteria. And there's a big push in cost effectiveness analysis to formally incorporate, for example, equity considerations, distributional considerations. But I will say that comparability makes QALYs still the most commonly used measure, even though we know that may not be the best measure of sensitivity, specificity, or really the measure that patients may care about. But is this a sort of comparability issue, and this idea that value is a relative concept that drives this towards this particular measure? And the other part that is important to understand, I should have written cost effectiveness analysis here, is that the difference between this value as incremental cost divided over incremental effectiveness and these issues of affordability or sustainability, because you need a different perspective, you need a different study to understand whether something that could be valuable, whether it's affordable or not, is a very different question. When I teach this, if any of my students is here, they have heard me say this a million times, but for example, I like to eat well and I like to cook. And before going to grad school, I almost went to cooking school. So I will say that, going to Alinea or any of the fancy restaurants in New York that it will cost you $500, it has good value. I still haven't been there because I don't think it's affordable for the things that I want to do, even though I think that is good value. So these are the different concepts that come from economic evaluations. And I'm exactly at 47 minutes and I have time for questions. Thank you.
Thank you so much. We do have a number of questions in the chat. And some of them you answered over the course of your talk. And so I don't know if you can see the chat.
Actually, I can. So if you can read me the questions, that would be great.
Sure. Okay. And so in one of your earlier slides, you mentioned sort of these different scenarios with the easy decisions and not so easy decisions.
Yeah.
And so in the not so easy decisions, aren't 1 and 2 essentially the same thing? Is how is more expensive and more effective different from less expensive and less effective?
Well, in the one that is less effective, say you are going to reduce the number of life years gained. So that usually we consider that to be bad. So you are going to essentially, the new alternative is going to reduce life years gained versus the other alternative. So that's bad. I mean, we usually don't like that. The other scenario is the new alternative is going to increase life years compared to the other alternative. So that's the difference between the two. That's why I mentioned that, I mean, sometimes in developing countries, you may accept use the medication that is not the most effective, but is the cheapest one because there's an issue of affordability. But usually, we don't do it because effectiveness studies of something that is less effective.
Mm-hmm. Our next question is, it seems intriguing for a budget impact analysis to also consider their perspective of what can be reimbursed alongside the cost for the unit of outcome. For example, the cost to enroll a patient into a remote diabetes monitoring program and the reimbursement for the remote diabetes monitoring program as they relate to the benefits of that remote monitoring. And then there's also the benefit of this program. Seems when things are reimbursed, it may throw off this ranking of ICERs, but wonder if it's okay to just offset the costs with the reimbursement and calculating the ICER.
Yeah, so remember, the key to all the discussions is the perspective. So like in the ICER, if you think about the ICER that way, we were talking about an ICER that is done with the societal perspective in which all the costs are considered. So that's one. But if you do a budget impact analysis, then that's different, and you will consider the impact, the financial impact of a particular intervention in one particular setting. So even the same thing, changing the perspective will change conclusion. So I think that the person was thinking about doing a study, say, from the perspective of the hospital. So that's a completely different type of a study in terms of the impact, the budget impact analysis. A ridiculous example, say that a cost effectiveness analysis of a tobacco cessation program. So if people stop smoking, their chances of a stroke goes down very quickly, particularly in the first 5 years. So from the perspective of a health system, from the perspective of society, say a 5-year study will show you that there is cost savings because, say, you provide Chantix that is expensive, but then the strokes go down. So say a health system saves money. Say from the perspective of the hospital, that's losing money because your patients, you don't get any money from Chantix and you don't have strokes. So the perspective matters. So that I think that's what makes the differences between that type of reasoning.
Mm-hmm, absolutely. And some of the other methods that we'll cover in the seminar series get at those different perspectives, different ways of conceptualizing whose cost and whose value and whose revenue are we really talking about. I really love Joanne's question here. I'm sure this comes up in your courses a lot. What are the ethical implications of creating a hierarchy based on finite healthcare budgets? And really, what other factors need to go into that decision and who needs to be at that decision table?
Yeah, so Yeah, there's a million. And I will say that, so that's a theoretical example. I mean, I don't think that any country has any ranking of anything, although they're called table leagues. And sometimes if you go to the cost effectiveness registry at Tufts University, they have like a long list of different interventions sorted by the ICER. But yeah, but nobody's sitting in a table doing that. But in some organizations like in the UK, NICE, and they do kind of make decisions based on this. And yes, there are a million ethical considerations in anything. For example, I didn't cover that, but say if we're going to measure productivity changes, the example of the laparoscopic surgery versus the regular subject and surgery, and then people cannot work for 5 days. So how do we put a monetary value to that? I mean, we could use wages, but say not to insult a politician, but say a politician makes way more money than a high school teacher. So if you use wages, so an intervention that is targeted to politicians will be more valuable than. So there's tons of ethical concerns on everything. There are also methods like we usually use an average wage in the population rather than wage to specific populations. And it is those ethical concerns that's why we don't do cost benefit analysis in health, because it will necessarily mean that we need to translate the outcomes into money, and that is like a ethical minefield. But I think that my view is that most people in health economics will tell you that the ICER is just one particular measure, and you should always take into account different type of measures, and that's what it's done in practice. Well, in the US, we don't do anything. I mean, by law, we cannot use the ICER to make coverage decisions. Medicare cannot do it. It is one of those compromises that came out of the Affordable Care Act.
And my question is, let's say I really didn't want to use QALYs. I didn't want to use the EQ5D, and I'm sort of sacrificing comparability. Is it generally appropriate to, in computing your ICER, instead of having your QALYs on the bottom, that you're just computing some other outcome, changes in some other outcome?
Give me an example of an outcome.
Depression scores.
All right, so your ICER would be dollars per, say, Hamilton score.
Mm-hmm.
Say that you find that is 20,000 per 1 unit of Hamilton. Is that valuable or not? Your problem, you can do it. It's just that when you try to publish in the discussion section, you are going to say, so we found this, and but we don't know if this is good value or not.
But in a comparative study, you might say,
if you have two of them, you could say then, yeah. Or if I compare my study versus another study that found that it was $10,000 per score of a Hamilton, yeah, I will say that, yeah, your study is more expensive and less valuable. But that's the problem. I think that a lot of the studies, you can still present the different units, but it becomes difficult to compare. And that's why we have the thresholds and QALYs, even though it may not be the best outcome. For example, the EQ5D doesn't even measure fertility. Say, if you do a cancer study of a breast cancer and medications like tamoxifen that may affect fertility for women, I mean, the QALYs will be terrible because it may, life years is important, but then you wouldn't take into account these fertility issues that are very important for patients. So you run into this problem of like, what is more appropriate for a particular situation versus this idea that you are comparing incremental cost with incremental effectiveness to decide on value.
Well, thank you so much. We are out of time for today. We really appreciate this. This was a great crash course and reminder of my health economics course from 15 plus years ago. Again, thank you everyone for staying and for your questions, and we will get this posted online soon.
Bye, thanks.
Bye.